Hi everyone. Hope you had a great week last week. Hope everyone had a lovely Thanksgiving, got at least a few moments to spend with some friends and family. I know in the online program, you don't get a lot of time off, actually, any time off, except for here at the end of this term, and that's faculty included. So I know that it was nice. I was able to take a few moments on Thursday to spend with my husband and son. So hopefully you were able to do the same, spend some time with family or friends this week, and get at least a small amount of downtime. So this week I actually, obviously in this class we don't have quizzes to go over each week. So what I did want to do is go over a little bit of additional information on risk. So it's less of a summary and perhaps a little bit more of additional info, but hopefully it'll add to what we talked about with risk, and specifically risk is part of the whole value system, and I just want to add to the information on risk. I was hoping to have a whole lecture on risk last week. That didn't work out, so I just want to add a little bit to what we talked about in the article on risk for last week. So obviously, the issue with healthcare costs in general, if you take a look at this graph, uh, you'll see that the highest percentage of members in any health plan are going to be in that far left category, spending $0 to a low amount of dollars. Our mean there is at that 44.59, but the challenge is to predict that tail. We want to know where is that tail going to be, and that's our challenge. That's our risk. Is how far is that tail going out? How many people are in that? So that's our challenge in the healthcare environment, especially on the payer side. So we kind of have to put our payer hat on here to try and figure out this risk, the side of risk. And we'll talk a little bit about the provider side as well, because there's, obviously now risk on the provider side in the accountable care world. So it's risk on both sides. So, risk adjustment in general is the process of adjusting health plan payments, provider payments, premiums to reflect the health status of those plan members. So, there's several different ways of doing it, and it's it could be as part of an accountable care plan. It can be as part of a multitude of different things. And in the ACA, really set forth some significant motion with risk adjustment. We're going to talk in a little bit of detail about the Medicare Advantage risk adjustment plan, but it really applies to a number of plans. So just to give you an idea of risk adjustment. So, like I said, we'll talk in a little more detail about risk adjustment. We're not going to go into detail. As I'll note at the end, I borrowed some slides from a few folks, made it a little easier to go through this. But I do want to talk about Medicare risk adjustment, because I think that a lot of plans um, build their basis on this, because many providers are familiar with this model. There are a multitude of models out there, and we'll take a look at that momentarily. But a lot of plans build their model on this because it's something providers are familiar with. So, Medicare risk adjustment model starts with the Medicare Advantage plan. So, Medicare Advantage, Medicare Part C, this is obviously our Medicare managed care plans. And they receive payment. And these are, if you're not familiar with these plans, these are folks that have opted out of traditional Medicare. So, instead of having Medicare Part A and Part B, traditional Medicare that you would get through the federal government, these are folks that have opted to have Medicare through a um, what what we would see, as someone that's just watching a television commercial, we would see them as as a commercial payer. It might be United Healthcare, it might be I don't know if UPMC or Highmark offer them, but it could be one of them if they offer Medicare Advantage. These plans are unlike if you have traditional Medicare, those are offered through the federal government through what are called administrative contractors, as opposed to Medicare Advantage plans, which are plans that are sold through commercial carriers. They're still government plans, but they tend to offer some wider benefits. Sometimes they have dental, sometimes they have vision, things that are not offered under traditional Medicare, but they do have this risk adjustment factor. So the Medicare Advantage plans get payment from CMS, Center for Medicare and Medicaid Services. Then this risk adjustment is used to adjust those plan payments to make sure that that there is adequate payment for the plans to provide services and cover benefits. So what is this risk adjustment? How does that occur? Well, each member gets a risk score, and that risk score is based on their health status and demographic characteristics. And they use what's called the HCC, or Hierarchical Condition Category Model. And this is based on diagnosis codes. So diagnosis codes are applied by providers, and there are very specific, and I don't, yeah, I didn't, there's another slide, but I didn't add it. There's very specific diagnosis codes. It's not every diagnosis code that the patient could have, but there are very specific diagnosis codes that are included in the mix. And so if a patient's diabetic, has renal failure, has specific diagnosis codes that are, a condition with complications, etc., this creates their risk score, and this can risk adjust their payments. So what's important about risk adjustment, from if you're interested in the provider side, is that coders are very accurate, because now, from a fraud and abuse perspective, the government is coming after providers for not being accurate. Because if you have a patient that is not as sick as you said they were in code, then you're getting nabbed for getting overpaid in those cases. And if you have somewhat of a pattern of that, and you've been found to do it on purpose, in a negligent fashion, with some intent to defraud, then you could be shown as actually committing fraud, as opposed to just making some errors in coding. If you just made some errors in coding, then in those cases you may just have to make payments back with some fines. But if you were intentionally defrauding the government, that could be bad from a risk adjustment standpoint. So now we not only have to worry about errors in billing and whatnot, but also with regard to this risk adjustment. So without risk adjustment, the payments were just made based on demographics. But with this risk adjustment, it incorporates their health status. So if you have a very healthy patient, then you'll get X payment. If you have a patient that is more ill, has chronic conditions, etc., it's going to hopefully reflect that cost. You'll get an additional payment for that particular patient. And you'll create that risk score, and like, for example, as this states, patients, typically you're eligible for Medicare when you turn 65. However, if you are if you're disabled, maybe you're 52, but you are disabled, this will, if Social Security has deemed you disabled, you would be potentially eligible for Medicare at that point. Or if you have end-stage renal disease, you may be eligible for Medicare at that point, even though you are not 65. So those would go into that risk score calculation. And then those health status factors, like I said, that would be within those diagnosis codes. What are ICD-10-CM is the diagnosis coding system that would all go into play for this risk score. So, higher risk score, greater than average burden of illness, lower risk score, healthier population, or one of two other things: inadequate or incomplete documentation, which is a problem that exists, unfortunately, or incomplete or inaccurate diagnosis coding, also another problem that exists. Unfortunately, although it is getting better, but unfortunately, a lot of practices do not have certified coders. They have folks that have been trained on the job and maybe are not certified, do not have the appropriate coding certifications, are not getting their appropriate coding training each year when the codes are updated. Maybe they aren't coding accurately. This HCC coding is a different system. It's the same ICD-10 codes, but it is a slightly more complex system. So it is important that folks doing HCC coding know exactly how to do that appropriately. So this is just a little model of what that looks like, of how all of the different pieces go into it: the disease hierarchy, disease interactions, demographics, diagnostic sources, and then a prospective model. So the diagnosis from the base year is used to predict payment for the next year. This is kind of complex, but the thing on this slide that I really wanted to show you is that on January 1st each year, the member's risk score is reset. So if a patient had a really bad year, if they were had a lot of conditions, a lot of things going on, but maybe they were acute things that just happened to fall within the model, but the next year it's reset, then perhaps if they weren't chronic conditions, that things are looking up for that patient. So when the risk score resets, you can't necessarily depend on certain payments to carry over from year to year. So from a provider side, you need to be sure that you're aware that the risk score resets each year. So this is just a list of, and this is a few years old, so there may be more. Some of these may be gone. You can tell it's a little bit old because it still says ICD-9, although this list was created after the conversion to ICD-10, but I did borrow this from someone. But you can see these are just some of those risk groupers that are out there. And up here at the top, DRG, hopefully you talked a little bit about DRG in your finance class, but this is kind of the original risk grouper. That is how Medicare inpatient claims are paid, and actually many other types of inpatient claims. But this is kind of the OG. The OG risk grouper of all risk groupers. And this is how Medicare hospital claims were paid. It was originally created by CMS, and that is it's called diagnostic risk groups, diagnostic related groups. It was originally that, but it's diagnostic related groups. Now it's called MSDRG for Medicare, but you'll see lots of different variations on that: APR-DRG, AP-DRG. But anytime you see that DRG, diagnostic related groups, diagnostic risk groups, it's related now, but anytime you see that, know that that's typically related to hospital claims, and it is kind of that original DRG model, was the original risk grouping. This is our HCCs that we were just talking about, hierarchical condition categories, that we were just talking about for those Medicare Part C, Medicare Advantage plans. But there are a multitude of others out there that can be used for different systems. Medicaid managed care plans can use these. Private payers can use risk groupers. The ACA plans use risk groupers. So those health exchange plans. So they can use any various different types of risk groupers. These that are noted as Ingenix, Ingenix is now Optum. So you'll see these as Optum now, but they have a risk grouper that's penetrated the market pretty well. So you'll see their stuff out there for risk groupers as well. So lots of them out there. They all do a lot of the same thing, but they use different data sources to come up with that risk score ultimately. Just hopefully a helpful overview of some of that risk grouping and how that works to go along with what we learned a little bit about how plans use risk. Please let me know if I can help to explain a little bit of that more. What else you want to know about risk? What the key is that it's important to plans to know that risk score, how sick patients are, because, as I said, and I'll go scrolling all the way back here, what we're trying to do is predict this tail. We want to know who's going to fall in this, and by getting that risk score or group those people together, it's going to help us to understand who's in this. Um, so I look forward to chatting with everyone in the discussion boards this week, and I hope everyone has a good week. Thanks so much.